Support for PupilPod is brought to you by Astellas Pharma US. Visit izervayecp.com to learn more about Izervay, avacincaptad pegol intravitreal solution, 2 milligrams.
Welcome to the Pupil Pod, where we use clinical cases to guide discussions on board review topics. I'm your host, Ogul Uner, and my guest today is Dr. Katherine Talcott. Dr. Talcott is a vitreoretinal surgeon and associate professor of ophthalmology at the Cleveland Clinic Cole Eye Institute. Dr. Talcott, thank you so much for joining me.
Thanks so much for having me. I'm happy to be here.
Great. We'll dive into our case. We have a 70-year-old woman with a history of intermediate dry age-related macular degeneration who presents with new wavy lines of vision on her home Amsler grid in the right eye. Best corrected visual acuity is 20/50 in that eye, 20/25 in the left eye. IOP pupils are normal. She has mild nuclear sclerosis in both eyes. And on dilated exam, you note several large drusen in both eyes with no retinal hemorrhages. An OCT through the right macula shows a fibrovascular pigment epithelial detachment, or PED, with sub-RPE and subretinal fluid. OCT through the left eye is notable for numerous drusenoid pigment epithelial detachments without fluid. Dr. Talcott, what are your initial thoughts about this case, and what additional information would you like to know?
Yeah, I think this is a great case, and this looks like a lot of patients who I take care of in clinic who have intermediate AMD, presumably in both eyes before, who then have switched over to neovascular AMD in sort of one eye. So whenever I'm seeing my patients who have intermediate AMD regularly, which is usually about sort of every 6 months, things I sort of want to know, like from them, is there anything going on with them that are risk factors that are modifiable for this disease? So one of that is like smoking, because patients will often ask what they can do to slow the progression of their disease, either to sort of the advanced dry kind, which would be geographic atrophy, or switch over to the wet kind. So I talk to patients about smoking. And then the other thing that I talk about is counseling regarding AREDS vitamins. That taking AREDS vitamins has been shown to decrease your risk of progressing to one of the later stages of the disease. So sort of that counseling. And then I always give people an Amsler grid to be able to take home to make sure that that they don't notice any change, such as like metamorphopsia. And so, it looks to me like this patient probably had intermediate AMD in both eyes before, but switched over in the one eye. Thankfully, it looks like we're catching it early because the vision is still pretty good. It's 20/50 in that eye. But, we look at exam to obviously make sure that there's no hemorrhage that's there, that can be an indicator that you've switched over, but it can also relate to sort of visual like prognosis for those patients as well. But OCT for a retina clinic is really sort of our bread and butter, and that's where we get a lot of our assessments from. So you're making sure in these cases where people have intermediate AMD to make sure that they haven't developed any sort of subretinal fluid. So the presence here of having a fibrovascular PED as well as sub-RPE and subretinal fluid, it makes me very concerned that they switched over to the wet kind of the disease. One of the things that you can think about doing for these patients is getting additional testing if you're not sure of the diagnosis. I think retina specialists used to get a lot of fluorescein angiography on these patients to be able to confirm that they were actually seeing like wet AMD. It can, and there's classic signs that you can sort of look for different disease types on that sort of imaging. To be honest, I think less retina specialists are doing FAs now than they used to, but OCT angiography is another helpful adjuvant for being able to detect if there's a choroidal neovascularization happening in these patients as well.
Great points. And you mentioned obtaining further imaging to look for macular neovascularization, or what used to be called as choroidal neovascularization. Could you talk about the different types of macular neovascularization?
Yeah, I can definitely talk about those. So there's 3 different types of NV. So there's type 1, type 2, and type 3. And just as a heads up, this is something you are tested on more than you will use in clinic on the regular, but it is good and important to know these things, especially at this stage of sort of your learning. So for type 1, which we sort of normally say is an occult CNV, that's where there's neovascularization, where blood vessels develop in the choriocapillaris and they enter into the sub-RPE space. Clinically, you'll often see just a little bit of graying and maybe some thickening of the retina. And then you can, on the OCT, usually see a fibrovascular like PED. You may see a double layer sign as well. On the FA, you will see leakage, but it's not always clear where the source of the leakage is there. That's in contrast to type 2, which is called sort of a classic choroidal neovascular membrane, where neovascular tissue comes from the choriocapillaris and then actually breaks into the subretinal space. So there you're more likely to see more subretinal fluid. You might see hemorrhage as well, and you can see what's called like subretinal hyperreflective material on the OCT as well. Type 3 is actually the one that I think is often most tested about because it's so different than type 1 and type 2. But this is where the neovascular tissue actually develops within the retina and grows within the retina itself. So it's a little bit different than type 1 or type 2. It's important to sort of know these different definitions because they were important in the sort of classic studies. But to be honest, maybe not as clinically relevant since we often treat these conditions pretty similarly.
I completely agree that these are very important for testing, but as you said, not so much in terms of treatment. And as you talked about with type 1 macular neovascularization, the leakage from unknown source or the fibrovascular PED are the classic hallmarks on FA, the well-defined area of leakage for type 2. And for OCTA, we look at flow, we look at if there's a membrane on the en face and just really ensuring it's not an artifact are the important points.
Yeah, I think those are really good points. OCTA is becoming a lot more helpful, and it's more present in more people's clinics. It can be really helpful if you see that there's fluid on the OCT, but you're not sure if it's really a choroidal neovascular membrane or not. So that can be a helpful tool to be able to get, especially since it doesn't involve any injections, any additional dyes. Of note, the reimbursement for OCTA just became possible this year, and the reimbursement that we get for OCT just standard has decreased. So I wouldn't be surprised over the next few years if OCTA becomes a more important part of practices and a more testable item.
Yes, definitely. And so we talked about how you examine these patients regularly. What else is in your differential diagnosis when evaluating a patient with suspected neovascular AMD?
Yeah, if you're seeing that there's fluid on the scan or there's hemorrhage on an exam, you want to think about sort of what's causing that. Common things being common, AMD is kind of usually it, and you would expect to see in those patients a high drusen burden. It's really important and helpful to be able to look at the fellow eye to give you information about the eye that they've converted in, because that will often sort of give you clues. So you would expect in the fellow eye, if it's intermediate AMD that's switched over to wet AMD, to be able to see drusen in the other eye. There's a couple other conditions that you should sort of keep in mind that can also sort of mimic this. Polypoidal is an important one. Those patients tend to get sort of more hemorrhage. You can see sort of polyps classically that are sort of there. You wouldn't really see drusen, and it's more likely to sort of get lesions that are a little closer to the nerve. Those conditions are also more common in people with Asian ancestry. So that's something to think about. Having a very myopic eye can also put you at risk for having a choroidal neovascular membrane. That will look obviously different than intermediate AMD. You might see some staphylomatous changes on sort of exam and on the OCT. Those patients often actually don't get a ton of subretinal fluid. It's more likely that they'll sort of get a fibrovascular PED and then hemorrhage on exam. So those are sort of important things to think about. And then central serous like retinopathy is also a mimicker that wouldn't respond to anti-VEGF injections and is important, as well as like a vitelliform lesion. These are what can be really helpful, not only as you examine these cases, but also being able to look at prior imaging if you have it available to be able to detect, if there's been a change or if this has been sort of a more like a degenerative process that's occurred.
I like how you mentioned, following these patients long-term to see if there have been any changes. And a lot of other disorders of the RPE and Brooks complex can result in macular neovascularization. We can think of certain uveitic conditions and, variety of other conditions like trauma. So Let's dive more into treatment, which I think is a very hot topic, and it's well tested on our boards and our OCAPs, available for patients with neovascular AMD. And you briefly answered this, but does the type of macular neovascularization affect your treatment decision, and why or why not?
Yeah, I think that's a really good question. It really doesn't. We're so lucky in the world of retina to have lots of different tools in our toolboxes, and those tools work really well. But we don't really choose different tools based on different types of choroidal neovascular membrane. So sort of our treatment, regardless of the type, is pretty much the same. And to be honest, some of the other things that we talked about in the like differential, including like myopic CNVMs or like polypoidal, we really treat in the same ways as well. So it's important to think about those differences because the prognosis can be a little bit different. But when it comes to treatment, we kind of end up in the same place, if that makes sense.
Specifically, what types of treatments are you employing? What is the mechanism of action of each? And what do you base your quote-unquote treatment success on?
Yeah, so anti-VEGF injections are really sort of the mainstay of treatment for these disorders. It's important to note because patients will sometimes ask that there used to be treatments available before that. So PDT is sort of one of those, which some people will call like a cold laser. And in the early sort of clinical trials, that's what anti-VEGF injections were actually sort of compared up against. It doesn't work that well for these conditions, so we're lucky to have something. They also used to just sometimes laser these lesions as well, but patients would be left with a scar and a scotoma related to that. There can be special circumstances where if someone has a large hemorrhage, you might actually consider taking them to surgery and using something like TPA to break up that hemorrhage. But really, by and large, we start these patients on anti-VEGF injections. We're lucky to have lots of different injections types in the retina space. So like bevacizumab is a common one that's often used. It's actually used off-label. It was approved for metastatic colon cancer, and it was found to be safe in the eye. So although it's off-label, it's been shown to be sort of safe and is very economic to be able to treat patients with that. In terms of on-label anti-VEGF injections, ranibizumab is another one that's been available for a long time. Aflibercept is another one. The 2 milligram dose of aflibercept has been around for quite a while, but just recently there was a high dose version of that, so 8 milligrams that was recently approved, and faricimab is another one. Brolucizumab is another agent that is approved for this condition as well, but in the United States it's not used as commonly because of some of the safety concerns associated with that. So there's a number of classic trials. I'm saying classic a lot, and it's making me think of classic lesions, so I have to be a little careful with my word choice. But there's some studies that it's probably good to be aware of. Marina is one of the studies that is often tested on. So this is looking at ranibizumab for minimally classic and occultant type 1. So that's one to know about. Anchor is another one to know about, which showed that the same medication was better than PDT for classic or type 2. The CAT study is an interesting study because it compared different agents that are available, bevacizumab and ranibizumab as well, which showed actually a similar sort of impact. Aflibercept was approved based on V1 and V2, and then there's other agents, so like faricimab or 8 milligrams of aflibercept that have also had recent trials as well. But there's a lot of things to know in this space, and so I'm sorry for everyone that gets tested on these trials. I know getting tested on trials in retina and glaucoma, it can be a lot.
Yes, there's a lot to know, and we really appreciate you going through some of the most important trials. I always thought about Marina with M for minimally classic. That's quite tested. Like they ask if Marina is had shown better efficacy for type 1 or type 2 lesions. And I always think M for minimally classic or occult. And then Anchor, the C in Anchor stands for classic. And so that's how I remember the two. And it's been really exciting to see how these agents have developed and have gotten different indications, beyond the AMD space. And really exciting to see now we're looking at gene therapy and other studies for wet AMD as well. So you talked extensively about different anti-VEGF agents. How do you choose which one to start with, and how long do you wait until you switch to a different agent?
Hot topics.
Yes.
There's entire retina conferences just geared at this very topic. I would say what agent you start with varies on a lot of things. And to be honest and to be frank, it actually comes down to insurance in a lot of cases. Some of these medications are very expensive, can be over $2,000 an injection. And so there's actually some recent literature just looking at how many patients, in order to get approval for these medicines, require prior authorizations, which take a lot of time, even though they almost always result in sort of approval. So it's a frustrating space. What's becoming more common because of sort of insurance mandates is starting with often like bevacizumab and then switching over to another agent once you sort of have approval. In general, regardless of what agent you use, if you start with bevacizumab or if you start on label with one of the other sort of medications, most people do 3 loading doses, so 3 monthly loading doses, and then you can take different approaches. In a lot of the early studies, and this is true for lots of different types of clinical trials, but patients were often treated with monthly injections, and those, to be honest, are the best outcomes that people get if they come in getting sort of monthly injections. However, that's a big burden on sort of patients, physicians, and can prevent us from having access to be able to get new patients in. So to be honest, the most common sort of treatment strategy that's employed by retina specialists is actually treat and extend. So you basically treat patients until they're dry, meaning that the intraretinal fluid or the subretinal fluid is gone. And then you continue on those injections, extending by a period of time. Often people will do 2 weeks. Some studies show that you can sort of go up to 4 weeks or even sort of longer, where you keep on injections, but you want to keep control of their disease. That means that every time you see a patient, you're doing an injection, but hopefully you're spacing them out. And then one final approach that people use, as opposed to sort of just monthly treatment or like treat and extend, is doing like PRN treatment. So you're only treating them if they have fluid. The hard thing with treating that is that somebody could have clinical activity in between their appointments and you're sort of not aware of it. And the thing that as retina specialists we get concerned about is if you're not sort of actively getting treatment, is that you're at risk for having this large hemorrhage that could be devastating to your vision. So I think that because of some of those concerns about sort of being able to miss something like fluid or there being a hemorrhage that's present, that's why most people do treat and extend, with the goal towards getting patients where they're on sort of maintenance treatment long term.
I think you summarized the approaches really well. And I think another challenge with PRN treatment is that you still need to see these patients very frequently, as you said, to really not miss things. So like they may still be coming into the office every 4 weeks, 5 weeks, not really getting the treatment. And that can be more burdensome for patients than a treat and extend approach where, hopefully patients get, maybe to 8 weeks or 10 weeks, and we have patients even extending longer. Great points that you mentioned.
That might be different in the future too. One of the innovations that will probably be available in the next 5 years or so is actually home OCT, where you can actually be able to do images on yourself at home if you're a patient. So that might allow you to be able to stay at home without getting an appointment until sort of the home OCT picks up that there's fluid, and then you would come in and then get your injection. So this might be different, and that's being investigated in studies now, is if using home OCT will allow patients to go further in between their appointments but still have good visual outcomes. So this could be a different world, but as it stands now, OCTs are really just in the clinic, so you got to come in. We just got to figure out when those intervals are.
Yes, and that's super exciting too. And we talked about different anti-VEGF formulations. What are some potential complications that you discuss with patients that are associated with intravitreal anti-VEGF, especially in people who are just starting treatment and aren't really aware of the process?
Yeah, it's funny because when we start patients on injections, and if they didn't hear about them before, they're often shocked to hear that they might need a needle in their eye. So we try and keep our safety conversations a little shorter, but injections are very safe overall. I tell patients patients that the major risks are risk of bleeding or risk of infection. Really, the one that I worry most about is the risk of infection, which is about 1 in 2,000. And I tell them that, unfortunately, if they get an infection, it would be serious, where we would, it's not something that would just go away with drops, but we would actually need to inject antibiotics into their eye themselves, and they could possibly lose their eye. So the things we tell patients is to watch out for is, especially in that week sort of following the injection, worsening pain, worsening vision. It's normal for patients to have some irritation the day of their injection, but if it persists beyond that, or if they were doing fine and then they're getting worse, they got to come in and tell us. Some of the other concerns that there's risk of if you're getting injections is having a retinal tear or like a detachment in the eye, as well as some fluid fluctuations. That's a little bit more of a concern now because some of the injections that we're putting into the eye are actually higher volume. So some research is being done to look at if those higher volumes are safe for the eye, which they do appear to be, but a concern for sure, maybe in someone who has advanced glaucoma, something like that.
I think the endophthalmitis is definitely the biggest risk that you mentioned. And then we briefly also talked about the safety concerns for brolucizumab, about like an occlusive retinal vasculitis that can very rarely happen. Fortunately, doesn't happen often with our other agents. What is the prognosis for neovascular AMD?
Yeah, that's a great question. It varies really depending on sort of presentation. The patient who we talked about in sort of our case example, we caught them very early. There was just some fluid there. The vision was actually still really good. So some patient like that I think is going to do really well, especially if they're monitored regularly and they're getting sort of regular injections. For patients who come in who have like large hemorrhages at their initial presentation, or if they already have a fair amount of atrophy, like pre-existing, the prognosis is not usually as good for those patients. It's possible that you can start injections on someone who has a large hemorrhage, and even though you're doing that, they don't end up having great vision. Sometimes fibrosis can occur because that hemorrhage has been there. So those are concerns as well. The other thing that we worry about is even if at presentation your disease doesn't look that advanced, there's always a risk that you could have a large hemorrhage. And that's sort of what I tell my patients when there's often fatigue about continuing to get injections, that if the disease is active, they're really at risk for having a hemorrhage at any point where it could be devastating to their vision and we wouldn't be able to get it back. And so that's the reason why a lot of retina specialists, myself included, really try and extend people to the point where they're on maintenance injections. But you really keep them on sort of some level of injections of frequency, maybe every 3 to 4 months, to just be able to control the disease enough so that they maybe decrease the risk of that from happening. And then the other thing that I always tell patients with this condition is if you've developed neovascular AMD in one eye, about a third of patients will get it in the other eye as well. Usually, if you convert in your second eye, those eyes actually have a better prognosis overall. Oftentimes, because they're already plugged in with a retina specialist, they know what to watch out for, and because we're monitoring them as well. And so often we catch those ones early, and patients are already getting treatment, and usually it's easy to facilitate, just unfortunately for the patient treating both eyes, but they're already kind of set up for success in terms of having a physician to see.
In some cases, do you see that if you take a PRN approach, do you find that maybe there is a period of quiescence? Like as a resident, I've seen some cases where the patient has wet AMD, but the disease looks inactive and they haven't been receiving injections for several months now. And we are not entirely sure what tipped them off, but they've been quiet and they're still under close supervision. How do you talk to those patients, especially if you need to restart the treatment, for example?
Yeah, I think that's a really good thing. That's true. Some patients probably don't need sort of lifetime treatment. We typically think about those being more common in patients who have like occult lesions, where they just had a little bit of fluid, you treated, it got better, but it might not ever recur. And even if there's little fluid there, they're probably not large at risk for having like a large hemorrhage. So what I typically counsel, or, what I think is more common in patients is I'll have them on sort of maintenance injections and then they'll get sick or there'll be sort of a gap in sort of our treatment. So you won't have seen them for about like 9-10 months and there's no fluid that's come back at all. Those are often the types of patients who I consider sort of switching over to PRN for as well. This population too is an older population. Sometimes it's a lot for people to come to their appointments with their caregivers. Sometimes people have dementia who have this condition, and it can often feel like in some cases the harms start to outweigh the potential benefits of injections. So those are often patients who I sort of think about doing PRN and then stopping for. If I do think that a patient does need to continue on treatment, even though there's been sort of a loss to follow-up and the fluid hasn't come back, then I'll sort of talk to them about the risks. The patients that I would sort of counsel or encourage more to restart treatment on is someone who's like monocular. Maybe they've lost the other eye to like to wet AMD and fibrosis, or maybe they have like geographic atrophy or something in the other eye. Then I'll push them a little bit more to restart treatment. But those are pretty nuanced conversations that, hopefully benefit from you having a relationship for the patient over a period of years.
And so going back to our patient who had subretinal fluid and sub-RPE fluid in the right eye, no fluid in the left eye, you did obtain an OCTA that confirmed the presence of type 1 macular neovascularization in the right eye. How would you approach treatment for each eye?
Yeah, so for the eye that has the neovascular membrane, then I'm starting injections on that patient. It depends on sort of what insurance allows me to be able to do. If I can use sort of on-label, great. But if not, then I'm often starting with off-label treatment, and I'll treat monthly until they're dry. And then once they're dry, then I'll start to extend them. If for some reason I have them on monthly treatment and the patient's not responding, then sometimes I'll switch over to another agent. I usually wait until I've given an injection at least 3 times before I do that. And then for the eye with intermediate AMD, I'm making sure that they're staying on their AREDS vitamins, and I really go over with them the AMP grid and to notify us if they have any changes. But to be honest, once a patient has switched over in one eye, they're usually quite diligent about coming in if they're having a problem in the other eye. What's more common is they'll come in with fluid and they won't have realized that it's there. Sometimes it's subclinical. And that's why every time I'm seeing a patient, I'm always getting an OCT on both eyes to be able to make sure that nothing's changing there.
Yeah, OCT has really revolutionized our
100%,
treatment paradigms.
100%.
So thank you for mentioning all of those great points. So let's summarize what we've learned from Dr. Talcott. Neovascular AMD is an advanced form of AMD that can be accompanied by sudden onset decreased vision, central scotomas, and or metamorphopsias. We talked about type 1 macular neovascularization, also called occult CMV. That's neovascular tissue from the choriocapillaris that enters into the sub-RPE space. We talked about how it can present as a gray or hemorrhagic membrane, a fibrovascular PED, or have a double layer sign on OCT, and has this late leakage of undetermined source on FA. We talked about type 2 macular neovascularization, also called a classic CNV, neovascular tissue that enters into the subretinal space. You can have more hemorrhages on exam, subretinal hyperreflective material, or SHRM on OCT, and an area of more early discrete hyperfluorescence that leaks on FA. And then we talked about the elusive type 3 macular neovascularization, also called retinal angiomatous proliferation, or RAP. It's neovascular tissue that originates within and grows into the retina. We talked about polypoidal choroidal vasculopathy and other RPE, Brooks membrane diseases that can resemble those in AMD, but the absence of drusen and the peripapillary location of the PCV lesions help distinguish it from AMD. We talked about different intravitreal anti-VEGF agents and that they are the treatment of choice in neovascular AMD, that ranibizumab is a VEGF-A inhibitor, aflibercept is a VEGF trap, and that faricimab has dual VEGF Ang2 activity. We talked about different trials showing ranibizumab's benefit in the Marina trial for occult CMV and the Anchor for classic CMV, and then the CAT and VIEW trials establishing non-inferiority of different agents and different intervals. We talked about most anti-VEGF protocols perform 3 monthly loading doses before assessing efficacy and deciding on either a treat and extend or a PRN approach, and the importance of continued AREDS2 supplementation in these patients who have non-advanced AMD in the other eye, as well as encouraging smoking cessation and regular AMSR grid monitoring to detect early changes throughout the treatment period. Anything else you would like to add, Dr. Talcott?
No, that was an excellent summary.
Great. And so, Dr. Talcott, before we end the episode, I ask all of my guests a question. My question to you is, if you could go back in time and give your younger self one piece of advice, what would it be?
That's a great question. So I would say that, I think back to sort of my 20s and 30s when I was sort of busy being a student and busy training, and life flies by very quickly. I would try and best that you can in sort of the quiet moments, really try and get quality time with the people who have been informative and like transformational in your life. Call your parents, tell you that, and make sure that you're telling them that you love them. Go back and see them when like you can. Same thing for your siblings and close friends. I remember always being focused on sort of doing the next step and sort of studying for things, but you really need to take things to center yourself and be present for the other people in your life as well.
Oh, I love that. I like how you really emphasized being present and really approaching your friends and loved ones and being grateful. So thank you so much for that answer. And Dr. Talcott, thank you for joining us on this episode of the Pupil Pod.
Thank you so much for having me.
And thank you to our listeners. See you next time on the Pupil Pod.